Jumping into the ankle and heel, essentially the protocol for the study is going to be 2 sagittal sequences, 2 axial sequences, and 2 coronal sequences. One which you can see is a non-fat suppressed, which is going to be better to look at the bones and the actual marrow signal, and then a fat saturated fluid sensitive sequence. So kind of what I do here is I'll sequentially kind of work my way through both of the sagittals, both of the axials, and then I'll end with both of the coronals. And you can use a combination of at least 2 different planes to come to a decision on most of the major structures that you're going to evaluate in the ankle and heel. So starting with the sagittal T1, I like just taking a look at all of the bones. You want to pay special attention to the base of the 5th metatarsal to make sure you're not missing an abnormality here. Otherwise, I'm just kind of seeing, all right, marrow signal looks relatively well preserved. Talus, calcaneus, distal fibula, and the distal tibia as well. Other thing you can kind of take a look at is the sinus tarsi fat here. You're looking to make sure there's no abnormal infiltration or effacement of this space. The other areas you want to look are along the talar dome to make sure there's no osteochondral lesion or bad degenerative changes here. You can actually see the really well preserved cartilage with the interface here between the talar dome and the tibial cartilage. And then the other thing that we're going to do is we can kind of clearly see the Achilles tendon is intact coming down here into the posterior calcaneus, as well as a portion of the plantar fascia with its calcaneal insertional site here. So when we go to the fluid sensitive, we're going to kind of do a lot of the similar things here. Make sure there's no abnormal bone marrow edema in any of the bones, particularly the base of the 5th metatarsal here. As you can see, there's really no kind of abnormal signal throughout any of the bones that we're taking a look at here. No significant infiltration of the sinus tarsi fat with edema or fluid. And then you want to take another look at the talar dome to make sure you're not missing an osteochondral lesion here as well. You can also gauge the degree of joint fluid. This would kind of be borderline normal or maybe a small ankle joint effusion here. And then what you really want to do is take a look at the Achilles tendon, as it's this kind of uniform dark structure coming down and inserting on the posterior calcaneus here. A lot of times you'll get a trace amount of fluid in this space, which is going to be retrocalcaneal bursal fluid. So one of the major kind of pathologies you'll see in the ankle is what we call the Haglund deformity. And essentially it's going to be a constellation of several imaging findings. One of being, is there tendinosis in the Achilles tendon, whether it be mild, moderate, severe? Gauge that by seeing how much actual signal abnormality is within the tendon substance. Is the tendon itself abnormally thickened? And then is there actual tearing, which you'll look for fluid type signal within the kind of distal Achilles tendon. Other things to look for, is there posterior calcaneal enthesophytes? Is there underlying marrow edema in the posterior calcaneus? Is there a moderate to large amount of retrocalcaneal bursal fluid? And then is there infiltration of Kager's fat pad here with edema as well? If you're seeing several of these findings going together, those are essentially the constellation of findings that'll suggest that someone may have a Haglund deformity. The other thing to kind of take a look at is the plantar fascia, as it's going to this calcaneal insertional site here as well. And we'll come back to this again when we're looking at the coronals. The next thing we're going to do is we're going to jump into the axial. So what I like doing first on the non-fat saturated sequence is I take a look at all of the bones again. You can see the distal tibia and fibula here. And then as we kind of come down here, I take a look at that base of the 5th metatarsal and all of the other bones to make sure there are no kind of major abnormalities here. And then you want to take a look at the muscle bulk here as well. Is there a lot of fatty infiltration? Is there atrophy a lot of the muscles or not? And then really what you're going to do is you're going to kind of divide the ankle into different compartments. So we'll talk about the anterior compartment first, then we'll go into the medial compartment, the posterior compartment, and the lateral compartment. So you're going to kind of anatomically run these 3 structures here in the anterior compartment, and kind of a mnemonic to remember what is going to be Tom, Harry, and Dick, being this is anterior tibialis, this is going to be your extensor hallucis, and this is going to be your extensor digitorum. The anterior compartment has the extensors. This medial compartment will have the flexors around the ankle and the foot. Usually if there's an abnormality in the anterior compartment, it's going to be tendinosis or tearing of the anterior tibialis tendon, which we can see right here. The next thing we're going to talk about is the medial compartmental structures. So the mnemonic is going to be a little different, whereas this was Tom, Harry, and Dick. This is going to be Tom, Dick, and Harry, being posterior tibialis. This is going to be your flexor digitorum, and this is going to be your flexor hallucis. So I usually will follow these structures kind of one at a time, both on the axial T1 and then on the fluid sensitive before I come to a decision of if the structures are normal or abnormal. So this is the posterior tibialis. This is going to be the digitorum going under the foot here. And then this is going to be the hallucis. And the point where this kind of intersects as it goes to the toe and the digitorum crosses over is going to be called the knot of Henry. And then you're going to have kind of medial ankle ligaments being the spring ligament and then the superficial and deep deltoid ligamentous complex. The deltoid ligament complex will be better evaluated on the coronal, but I do like taking a look on the axial here at the spring ligament, which is this wavy kind of structure here, which we'll take another look at on the fluid sensitive sequence. Going into the posterior compartment, you can see Keyur's fat pad right here. This is going to be the Achilles tendon. When you're gauging tendinosis, I tend to like thinking of the normal morphology of the tendon as kind of having a smiley face. So it should have a little bit of curve. Once that flattens out or becomes convex, you're going to have definite tendinosis. And then as we come to the lateral side, you can see there is an overlap of two structures here. These are going to be your peroneal tendons, peroneus brevis and peroneus longus. Brevis tends to be kind of on the inside of longus. And if you ever get confused, you can always follow it back from its distal insertional site. Peroneus brevis inserts on the base of the fifth metatarsal, and we can kind of track it back here into where it becomes kind of a little bit more well-formed here. Same thing with longus. We follow it here as it kind of extends more distally. This is kind of one of the more difficult structures to evaluate in the ankle because it's prone to have a lot of artifact as the structures are curving along the bottom of the fibula or lateral malleolus and continues to curve distally here as portions of it go under the foot. So I like taking another look at these on the axial fluid sensitive as well as the coronal sequences as well. The axial is great here to kind of be a guide to identify all of the lateral ankle ligaments. So you can see here, we're still at the level of the tibia and the fibula. This is going to be your AITF. This is going to be your PITF. AITF being anterior inferior tibiofibular ligament, PITF being posterior inferior tibiofibular ligament. And these are structures that will obliquely go craniocaudally. So you kind of have to scroll up and down a little bit to get a full look at them, as you can see over multiple slices here. And really what you're looking for is it abnormally thickened to suggest that there's a chronic sprain, or actual periligamentous edema to suggest a more acute sprain, or actual full thickness discontinuity to denote a full thickness tear or a grade 3 high grade sprain. As we come a little bit more inferiorly, then we're going to get into the ATFL, which is going to be the anterior talofibular ligament, which we can see here. This is going to be the PTFL, the posterior talofibular ligament. And then the last structure is going to be the calcaneofibular ligament. Try to find this bump here on the calcaneus, and you can see how there's a little bit of thickening here. And you're going to follow that as it goes straight up or superiorly into the base of the fibula. This is a portion of it here as well. This is a portion of it here as well. And we'll take another look on the fluid sensitive and the coronal sequence as well. These usually are abnormal in a stepwise order, with ATFL being the most commonly injured ligament, followed by CFL, followed by PTFL, which is honestly a very, very strong ligament. And it's honestly pretty rare to see abnormalities with the posterior talofibular ligament. So now coming into the fluid sensitive sequence here, I like running all of the structures again. So like we said before, Tom, Harry, and Dick, anterior tibialis, extensor hallucis, extensor digitorum. We're going to follow these distally. We're going to see if the tendon is abnormally thickened, abnormally flattened, or has increased signal to suggest whether there's tendinosis or not. And then we're going to do the same thing with the medial compartmental tendons, being Tom, Dick, and Harry, posterior tibialis, flexor digitorum, flexor hallucis. So we're following the posterior tibial tendon here as it kind of comes out here more distally. Same thing with the digitorum. Same thing with the hallucis. So you can see there's a little bit of fluid kind of outlining some of the tendons, and this is where we can talk about if there is tenosynovitis, which is going to be, you're going to gauge whether it's mild, moderate, or severe, and it all is related to how much fluid is circumferentially enveloping the actual tendon. A lot of times, true tenosynovitis is when you're going to see a little bit of the slip that attaches the tendon to the circumferential tendon sheath going around the tendon. This is probably what I would just call a trace amount of non-specific fluid rather than it being true tenosynovitis. The other thing we can kind of talk about is the concept of posterior ankle impingement, which is going to be one of the other things that's a constellation of findings. What you look for on the sagittal is there variant anatomy with the posterior talus, striatal process, or an os trigonum? Does it have edema associated with it? And then on the axial, what you tend to see is stenosing tenosynovitis involving flexor hallucis, which is going to be that circumferential fluid within the hallucis tendon sheath, but it kind of starts, stops, and a lot of times at this knot of Henry, you'll get some fluid that gets held up there as well. Keep in mind that there can be a small amount of fluid in the flexor hallucis tendon sheath because it communicates with the joint space. So if there's a lot of joint fluid, it can extend or decompress into the flexor hallucis tendon sheath. The next thing we're going to do here is take a look at that spring ligament. You can see it's pretty uniformly low in signal, this wavy structure here as well. And then we can also kind of talk about the concept of another imaging finding called posterior tibial tendon dysfunction. So radiographs can be important in the feet, particularly for if there's variant anatomy with the navicular bone. Is there an os navicular? Is there a prominent cornuate navicular? Is there marrow edema associated with it? And it can predispose the posterior tibial tendon to having tendinosis, tearing, and tenosynovitis. And one of the other things you can look for on a weight-bearing radiograph is a flat foot deformity. When posterior tibial tendon dysfunction goes unchecked, you're going to get tendinosis, tearing in the posterior tibial tendon, edema in the variant anatomy of the navicular, and you're going to get a flat foot deformity and infiltration or abnormal signal in the sinus tarsi fat as well. So the next thing I do is we're going to take a look at the Achilles tendon here, which we can see is uniformly low in signal. Not a lot of signal abnormality. You can see some of that retrocalcaneal bursal fluid here as well. And then we're going to get into the lateral ankle as well. So this is our brevis, this is our longus, and what you want to do is just kind of follow them kind of one at a time as it kind of goes under the malleolus here. So the T1 kind of looked a lot worse than the fluid sensitive, and it's one of the reasons you want to look at it on multiple sequences. So on this sequence, they're pretty low in signal. There's not a lot of signal abnormality. There's no circumferential fluid to suggest tenosynovitis. This kind of diminutive appearance is just going to be related to kind of the volume averaging as the structures are curving, and this is going to be a little bit of brevis as it inserts distally at the base of the fifth metatarsal. So coming all the way back here, we're going to run the ligaments. So AITF, no periligamentous edema. You're going to have your PITF here. And then as you come more inferiorly, this is going to be your ATFL, which is not thickened. There's no periligamentous edema. This is going to be your PTFL. And then as you come down, this is going to be your CFL. As I kind of scroll up and down, if you can kind of see it contiguously, kind of going up and down as it kind of inserts on the fibula, bottom of the fibula there. So one of the common test question type things is going to be, you're going to be shown kind of an image, and really the important thing to do is how high up are you or how low are you? Because they're going to try to get you to quickly just call the AITF, or anterior inferior tibiofibular ligament, the talofibular ligament. And it's a very, if you're going too fast, a very easy thing to confuse. So you can see at this level, we have not gone down far enough. This is still anatomically the tibia, so you know this is the AITF, versus if you're down more inferior, you're going to see the talus start to extend more anteriorly, so you can know for sure that you're at the level of the anterior talofibular ligament. And now we're going to come into the coronal sequences. So we're going to have our coronal here. one being the T1 non-fat saturated, and then you're going to have the fluid sensitive. So as we open this, what I like doing is taking a look at the intrinsic foot musculature to make sure that the muscle bulk is relatively well preserved. When you have asymmetric fatty infiltration or atrophy of the abductor digiti minimi musculature, that's something that can suggest Baxter's neuropathy. The other thing I look for here are the different bands of the plantar fascia. This is going to be the beginnings of the central band. This is going to be the medial band, and this is going to be the more lateral band. And as you can see, they're going to kind of come together here to converge distally or more proximally, I should say, as it goes to the calcaneal insertional site. The threshold we kind of use, commonly the central band is more abnormal than the medial and lateral. Look for about 4 millimeters of thickening, and then is there signal abnormality within the plantar fascia, overlying the plantar fascia, to suggest if there's active plantar fasciitis. The other thing that the sequence is very good for is make sure you look along the talar dome to make sure there's no osteochondral lesion, usually along either the medial talar dome or the lateral talar dome here. And then the other thing I like doing is taking a look at the deltoid ligamentous complexus. So really you want to see, is there any osseous remodeling of the medial malleolus or the medial portion of the talus to suggest that there was a prior injury? And then this is going to be the deep deltoid ligamentous complex here. And you're going to have a stepwise kind of order of structures as you start to get more superficial. If you can kind of imagine this is all deep deltoid, this is going to be the superficial deltoid, and then this is going to be the flexor retinaculum that is overlying both of the more superficial and the deeper deltoid ligament complex. And so now we'll get into the fluid sensitive sequence. Same thing, you want to make sure there's no osteochondral lesion here. We're going to take a look at the plantar fascia, make sure there's no signal abnormality as these are converging as it inserts on the calcaneus here. And then you can take another look where you can see the striated kind of pattern for the deep deltoid ligament complex, the more superficial deltoid ligament complex, the flexor retinaculum. And then sometimes it can be a little difficult to see the spring ligament. I find the axial, you will have a little bit more success identifying it than on the coronal, but it can just be kind of variant based on a case-by-case basis. And then if you're really having trouble with the peroneus brevis and longus, I like looking at these on the coronal as well as kind of a tiebreaker. And you can kind of see the two tendons side by side here. As they're dropping under, you can still see they're pretty low in signal without a lot of signal abnormality as well. And as we get here, they kind of disappear due to kind of artifact on the imaging study. So going back to the axial, the other thing, when you're looking at the peroneus brevis in particular, it's prone to have this split tearing where it'll almost look like a forked tongue, and it'll either be retromalleolar or inframalleolar in location when it typically has that pathology. So that's just an additional thing to look for.